they took all the people who were in this study once they had the result, as well as 2 other randomized studies that were like it, one of which involved youth, 18 to 24. And they rolled them over into this study called PrEP. Olé. And Olé stands for Open Label Extension, because they said, okay, whatever you were on before, whether you were on the sugar pill or the real pill, now we're going to give you the real Truvada pill everybody knows, and we want you to take it, okay? Do you want that? And the first thing they noticed was 76% of the people who were offered it actually said, yes, we want it. So I don't know if that's a good number or a bad number, but it's 3/4. I suppose it's better than 50%. But these are people who came into this study wanting to take a pill for HIV prevention. Now that you know that it works, only 3/4 of the people wanted to really take it. I don't know what that says our ability to have done good education with the trial participants and communicate the results of the trial in a way that people understood the potential of this. Or maybe it just says, maybe people don't want this. And I think that's a lot of work to be done to figure out how people who are most at risk for getting HIV learn about this, know about it, and figure out if they're going to use it. But we'll come back to that too. So in this open label extension trial, they did some even fancier work. This Alu stuff was just like the tip of the iceberg. They got crazy here. On all the patients, they took a piece of filter paper, and when they drew blood on people, they took 20 microliters, which is like a pin drop worth of blood, and they put it on the center of that filter paper. It's called a dried blood spot, or DBS. And you're like, well, what are they going to do with that? You remember in like kindergarten, those like hole punches that you would use to make a single hole punch to like put something in a 3-ring binder? So they took that piece of filter paper and they hole punched out the blood spot, and they ran it through a machine that analyzed the amount of Truvada drug in the red blood cells. Now, the reason that's important is red blood cells live for about 90 days. So they could tell you, on average, how many doses a week of the Truvada people took in the last 90 days. So it's not like a drug level that you might take right when you go to the doctor's office that only tells you maybe how someone did in the last 2 or 3 days. This tells you, it's sort of like, for those of you who are medically inclined, there's this thing for diabetes called a hemoglobin A1C. It measures how high your sugars are over time. This is a hemoglobin A1C, but for Truvada adherence. Crazy, right? This is pioneered by this guy at University of Colorado named Peter Anderson. He's kind of a genius. So he did this, and he found out, and this is a result that gets sort of screamed from the rooftops when this study was published in July of this year, is anybody who took 4 or more doses a week on average did not get infected at all. Personally, I think that's a little bit of a dangerous message. I don't think we know that, because that's an average number. Let me give you a couple scenarios. Let's say I was taking my Truvada every day without fail for a month, and during that time I was having a lot of sex. And then I stopped taking it for the next 3 or 4 weeks. My DBS blood levels might look like, on average, over the last 3 months, I was taking 4 to 7 doses a week, and I was protected, but maybe it's because I wasn't having sex when I wasn't taking it. What we don't know is how many missed doses in a row, or how intermittent dosing with relation to when you have the exposure protects you. We don't know that yet. So I get kind of hives when I hear people saying, as long as you get 4 doses a week in, you're fine. We don't know that. What this result says to me is there's some forgiveness. You can miss a dose here or there and probably be okay. But it would be irresponsible of us as providers and educators to tell people that we can recommend taking it less frequently than every day at this point. People are studying other regimens and other ways to take it that's not every day, but we don't know yet. And the last thing you want is for someone to think that they're protected and end up getting infected anyway. Okay? That's what we know about men who have sex with other men and transgender women about the efficacy. But at the very beginning, I raised a number of concerns, didn't I? I said, number one, what's it going to do to people's sexual risk? Right? This has there's sort of a medical behavioral science term for this. It's called risk compensation. Basically, it means, are people going to toss their condoms out the window because of this? And remember, this protects you against HIV. It doesn't protect you against gonorrhea, chlamydia, syphilis, warts, herpes, right? So all of those things increase your chance of getting HIV infected. They increase your susceptibility, right? So if people get STIs and they're not treated, you can be at more risk. So people have done these mathematical models that if people even increase their number of partners or their unprotected partners by a little bit individually, across the world, we could actually see an increase in the HIV epidemic because PrEP isn't perfect, right? Nothing's perfect. So this is an important question that we need to answer. Next question, resistance, right? Okay, obviously people are getting infected with HIV even though they're taking PrEP. And Truvada is a key component of the medicines that we use, the cocktails that we use to treat people who are HIV positive. So if somebody breaks through, I'm putting that in quotation marks, Truvada-based PrEP, are they harder to treat? Do you then have to use different medicines that are less well tolerated? And then a lot of people who like doomsday scenarios will tell you it's going to start a whole new epidemic where everybody's getting infected with Truvada-resistant virus. And that's scary, so we shouldn't do this. Another argument. We'll come back to that too. Disparities. Right? So everyone knows that there are communities where HIV is incredibly stigmatized already. And a lot of those individuals have less access to HIV care and health care in general. If this costs a lot, how are we going to make sure it gets to everyone equitably so we don't exacerbate already existing disparities in the haves versus the have-nots? Is this going to be something that only people who are educated, wealthy, privileged, already in care are going to be able to access? Or is this going to make the entire HIV epidemic worse by singling out people who can't access this, doesn't matter how powerful it is? If anyone has an answer to that one, I'd love to hear it. And then another important one is who is going to prescribe this, right? Who knows the most about HIV medicine prescribing? It's the HIV doctors or the HIV providers, right? But those people usually see people who are already HIV positive. So who sees the at-risk negative people? Primary care doctors. You all know that primary care providers are very busy, have very short appointments, have a lot of priorities, a lot of times aren't comfortable prescribing these medications, dealing with the side effects, and with HIV testing. And then what do you do if somebody seroconverts, and how do you manage that? People like to call that the purview paradox. What that means to me is everybody putting their finger on the side of their nose and saying, not me. All the HIV providers are saying, I'm too busy, clinics are too full, I may know how to do it, but I don't have the capacity to take on a whole bunch of negative people to do this with. Primary care providers are saying, not me, I don't know enough about this, I'm not comfortable. And my favorite story was the time I got referred someone from one of the primary care doctors in the UCLA medical system. Why? To take a sexual history. No lie. In order to talk about this, you need to talk about sex. You need to understand risk. You need to be able to have a conversation about how people are or are not putting themselves at risk. A lot of primary care doctors, or primary care providers, I need to stop saying doctors, don't want to or aren't comfortable doing that. That's a problem. So who and where this should be done is a big problem. If you're negative, do you want to, particularly if you come from a community where HIV is still extremely stigmatized, be seen walking into a place that's identified where people get HIV care? A lot of people don't. So where do you put this? Now, I don't presume to have answers to all these questions, but I can tell you a little bit about what we do know. About sexual risk. People call this the belt and suspenders conversation, right? If you're wearing a belt to keep your pants up, are you also going to wear suspenders? No, of course not. That's silly. Unless you're making a fashion statement, right? But the point is, are people going to all of a sudden throw condoms away and if they're using PrEP? So all of the randomized studies, like the PrEP study that I told you about, there are actually 4 other studies in different populations that I didn't tell you the details of. We can talk about them if you're interested. I didn't want to bore you to death. That showed that numbers of partners and condomless sex actually went down over the course of the trial. Didn't go up. There were not more partners, and there was not more condomless sex. So I would argue to you that, well, that's nice. That doesn't tell me anything, because if I enrolled you in this study and said, hey, want to take a pill? It might work, might not. Or you might be getting a sugar pill, 50-50 shot, so you better keep using condoms. Are you going to go out and throw your condoms away? No. Probably not, right? But if I now tell you, hey, this works maybe as well as 99% if you take it every day, and you know you're getting it, is there a possibility that you're actually going to toss the condoms away? Yes. And they didn't see that in this PrEP study. Again, condom use actually went up, and numbers of partners was the same or slightly decreased. I will tell you that other STDs stayed the same, which makes you wonder. It didn't go up, that's good, but it also didn't go down. So I'm not sure that I believe that people really were safer, but at least it's a little reassuring that maybe people didn't put themselves in harm's way more. My personal theory is that there's a whole group of people out there in the world who are just fine with condoms. Maybe we don't love them, but you use them because you understand that they're protective. And then there are people who just aren't, for whatever reason. They can't, they don't, they won't. Those are the people in whom the new infections are occurring, right? So this protection is really most beneficial to those people. Are there some people who kind of hate condoms but feel like they need to do the right thing, and so they kind of try and they don't really succeed? Yeah, probably. And might those people be pushed one way or the other? Maybe. But I really think that people in general fall into those 2 major groups, people who do and people who don't. That's my personal theory. That's not necessarily borne out by any data or any studies. And you can tell me that you disagree, please do. So this remains something to be determined in real clinical practice. We don't know the answer yet. Resistance. We've not seen it except in one clinical scenario. You all know that every HIV test has a window period, right? You can be infected, but the test hasn't yet turned positive. And depending on what kind of test it is, that window period is a different amount of time, right? The most commonly done HIV test is somewhere on the order of 3 to 4 weeks, depending on which test we're talking about. That's just your general HIV test. There are some newer tests called 4th generation antibody antigen tests that are somewhere on the 10 to 14 day window. They're better. And there's the viral load test, which is the most sensitive test, which is 5 to 7 days after an exposure. But the most common one that's done somewhere on the 3 to 4 week range. So in the PrEP study, the only people who got resistance to Truvada were people who had a regular HIV test that was negative, and it was negative when they started the medication. And they showed up positive at the 4-week time point after they had started the medication. And they went back and they did the viral load test, that ultra-sensitive test on those earlier blood samples that they had stored away. And it turned out they were super positive. So those people were really in that window period when they started the Truvada-based PrEP. Those people got resistance to Truvada. Everybody else who actually got HIV while they were on the study, they didn't have resistance. Without boring you to tears, I'll tell you my theory as to why that is. I think the rates of resistance look something like this. Oh, that's kind of phallic, isn't it? That was not my intent. So this is adherence. When people don't take the medication at all, and they get exposed to HIV, you get infected. But there's no medicine around to get resistant to, so you don't get resistance. There's some level above which, if you're taking the medicine often enough, you don't get HIV infected, so you don't get resistance. There's some area in the middle, we don't know how wide it is, where that point is, where you're taking it not enough to protect yourself, but enough to still get resistance. And I would bet you that it's really people who aren't taking it, get infected, and then start taking it after they got infected, but they didn't know that they were infected. I bet you. I cannot prove that, but that's what I suspect we'll end up seeing. In that study, they tested people every month. Now, there are some people, some patients, who will be okay getting tested every month. The CDC guidance and the WHO guidance on how to use PrEP says test every 3 months. So that's a much longer time period during which if someone wasn't taking it, they could get infected and then say, oh yeah, I should be taking my PrEP, and start it again and take it for a while before they come to a test that would identify them as positive. So I worry, now that we're using this not in a clinical study context, that we may see more resistance. But we don't know the answer to that question yet. That makes sense? Sort of. I haven't put you to sleep just yet. Now let me try a little harder. Okay. So, disparities. I got nothing to say to this except a challenge. To our public health colleagues. I think the question, if we're going to use PrEP as part of our prevention menu, is to figure out how to make sure we make it accessible to anybody who's at risk, regardless of their ability to pay, regardless of their ability to get on ACA-funded insurance programs. And it's going to take a real collective, collaborative effort to figure out how to do that, how to leverage insurance support when it's available, but how to be a payer of last resort for people who don't have access to that. I think, personally, that that's the only way we're going to prevent this from exacerbating existing disparities. The WHO, I have no idea about this one. I'm an HIV provider, and I see PrEP patients because nobody else will. And I think it's important, so I do it. I've had a lot of providers call me and say, is this a crazy thing to do? My patient asked me about this. I've had patients call me in tears because they went to a provider who slut-shamed them for seeking PrEP. Said, you must be promiscuous if you want to do this. And my response is, I think it's an incredibly brave thing to do to take charge of your own sexual health and decide that you want to protect yourself. And a lot of people don't agree with that. And we can have a political discussion about it, we can have a moral discussion about it, but I think the bottom line is what Eric and Rob introduced this talk with is there are 50,000 new infections in the United States every year. That has not changed in the last 10 or 15 years. Everything that we are currently doing is not impacting those incidence numbers. We need something else. Should this be in the water? No. Is this for everyone? No. Should this be an option for people who want it? I think so.